Hey, so now we're live, Dennis, and
hello, everybody.
All our friends in the audience can see you now. Roger, you and Susie can.
Martino, what are you on here for? Then I've got Steve Fletcher on here, so I'm going to have to behave myself as far as ABC.
Exactly. You know, they're watching you, man. They love to hear you. It's great. Hi,
all right. It'll be fun.
Merry Christmas to you too. Hi, Nikki. Art. Hey, buddy. How are you? Oh, he said wrong, Steve.
Oh, Dave Cardello's here.
Yeah.
My goodness.
Look at that. We got them all.
Okay. Anybody that I recognize can't ask questions.
That's great. So I think, we got like 78 people in the room right now. I think we'll give it a couple more minutes.
Okay.
It's Steve from Richie's. Steve Fletcher from Richie's.
No. Is that who that was?
Yeah, that's it. Yeah.
Oh, okay.
Hey, Giuseppe. How you doing? Aaron Anderson says hi. Can you see all the comments? Oh, you're looking at the people right now.
No, I don't see the comments. I don't see them.
If you go, so you see where people are, where you click people, just hit the comment box to the right and you'll see everybody.
Oh, okay.
Hey, Cardillo says hello. Hey, Derek, hey, buddy.
Oh, there they're going. I see. Giuseppe's here. I haven't seen them.
Nice to see you too. Hey, let us know where you're from. Let us know, what part of the country you're from.
And how locked down you are.
Exactly.
I live in this nice little bubble of West Bend, Wisconsin, and we only wear masks when we have to. We misbehave all the time.
That's right. They are in the Midwest.
Yep.
Hey, Sal, welcome. Joan, welcome. Michael.
Oh, now we're going crazy. Okay.
How you doing? Tim from Hanger, Missouri. Oh, we got somebody already wanting to grab the mic. Actually, Shashikant, we're gonna wait a few minutes to grab the mic. We're gonna introduce the platform and people and kind of get Dennis's presentation going.
Hi, Eric from Madison.
Yep. We got Sharon from Pennsylvania. Welcome. Matt from Virginia. Teresa says hi.
Hi, Teresa.
Oh, that's awesome. We just did that great PFA event on the 6th about a month ago. So this is great. I'm looking forward to getting this started. Hey, Julian, welcome. Leroy, Gene, Nelson, Massachusetts. Will there be a recording? Yes, there will be a recording. We record every session. It'll be available usually within about 24 hours of the event. Awesome. Hi, Catherine. Yeah, go Packers. For sure.
There you go.
Nelson. Hey, Martin. How you doing, buddy? All right. So I'm going to get this started. So good evening, everyone. Happy holidays. Greetings from the PFA. Welcome to the Understanding Causes and Management of Partial Foot Amputations, powered by LER Expo. This is a free event worth 2 CEUs and comes courtesy of the PFA. Many of you know already, my name is Rich Dubin. I'm the founder and publisher of Lower Extremity Review magazine and the CEO of LER Expo. I've been in the lower extremity space for 30 years, and I'm just so incredibly honored to be working with the PFA and facilitating this awesome educational event. So before we begin, obviously you're all letting us know where you're from, so that's really fantastic. I love this space we're in right now because at least it gives us a chance to connect with people from all over the world, as a matter of fact. So this is great. I'm glad everybody's here. We got currently have about 111 people in the room and more coming in every minute. So that's just awesome. So I want to just go over a few housekeeping items, so you know how the platform kind of functions and kind of what the little things, what the emojis are and how to comment. Obviously, we all know how to comment. To the left of that are 3 emojis. You guys can kind of play around with those. Obviously, you see the clap and, the mind and laughing. And so if you hold down your mouth over it, kind of a little fun. kind of pops your name up there. You can clap. And what this does is this gives you a chance to let the speaker know kind of how they're doing. It's really important. One of the things that make a great event is the engagement. So we really need your help with that. The chat's obviously in the right. One of the cool things on this platform is to grab the mic. We already had someone try to do that, but we're going to hold that until the end, until Dennis's presentation is done. So to the left, on the left side, you'll see a mic. And if you grab the mic, you come up to the stage, come up to the screen with Dennis and I. You can ask your question in person. And I think it's great to see everybody. It really would. Welcome, Anthony. Welcome, Housep. Victor from Naples. Must be really warm down there. We had some snow up here in New York today. And then what other cool thing is you can see up on the top right the number of people in the room. You can click on people. You can look at suggestions or connections, and you can send a direct message. If you do send a direct message to a colleague, you'll see up on the top right the little message. It'll come up with a number. Right now, actually, I have a one. Hey, LA Ward, how you doing? So that's a cool little feature. Keeps everybody kind of connected, and I think that's really important for these type of environments that we're in right now. So I'd like to introduce our first speaker. Many of you know already. It's Dennis Janessi. I've worked with Dennis. I've known Dennis for over 30 years, and I've worked with the PFA for that long. You might all know this, you might not, but Dennis is the president and CEO of National Podorthic Services, a network of full-service podorthic facilities. In addition to his duties at MPS, he is the clinical assistant professor in the Department of Physical Medicine and Rehab at the Medical College of Wisconsin, teaches podorthic courses at Northwestern University Medical School and the Medical College of Wisconsin. He is the past president of PFA, an honorary member of the American Orthopedic Foot and Ankle Society. He's written extensively about all aspects of podorthics with over 50 publications to his credit, and he's lectured all over the world. Basically, as you all know, Dennis is the podorthic encyclopedia. So, his presentation is going to be about an hour or so, and there'll be time for Q&A after his talk. So please try to hold your questions. And as Roger said, ready to learn from the master.
And Roger's full of baloney.
So listen, engage, and retain. So we really want you to stay engaged, and that's how we learn. So without further ado, I'm going to turn it over to Dennis, who will share his PowerPoint and get that ready, and then tee that up, and then we'll get this party started. We got 125 people in the room. That's incredible. That's how many we had at the PFA, Dennis, a month ago.
All right.
So we're going to get it started. Enjoy, and I will see you after the event.
Are we there, Rich?
Yep, you're there, brother. Thanks so much.
Right.
Go for it.
Thank you for that introduction. I want to, obviously I can't see all the names now, but I see a whole lot of names that I recognize. Thank you guys for putting up with me for an hour or so. I do want to reach out to some of my Thai family. I've got a lot of students in Thailand, and I saw that some of them are here too. So welcome to you from Thailand and everyone from all over the United States. I don't know if we have anybody else international. I know there's somebody from Croatia that could possibly be here as well. So welcome everybody. It's great to be here. This is not the way I want to do presentations next year. I'm not really comfortable with this. I like to have feedback from all of you folks, but obviously for the time being, this is the way we're going to do it. Seems like I'm already finding meetings that are going to happen next year. So hopefully we'll be able to see each other face to face sometime next year. So we're going to talk about causes and management of partial foot amputations. And some of you definitely have seen this, or at least a version of this talk. So bear with me. Amputation surgery, oldest of all surgical procedures. And, really, I think you think of looking at history books, you saw pictures of old drawings anyway, where they were sawing somebody's leg off. It certainly was the oldest procedure, one of the oldest procedures. They didn't know much about what was going on inside, but previously a life-saving destructive procedure, obviously, but now it's a reconstructive procedure, and it really can improve the person's life and make our job easier as well. Amputation requires judgment, planning, and meticulous handling of marginal tissues, and I know that's the case with any amputation. Certainly, the prosthetists need, if they're going to do a below knee, if they've got a below knee amputation, they're going to make a prosthesis. They need a good result of that surgery to work with. But I think it's so much more important, and it's so much more intricate with the foot. I mean, we've got 26 bones, and when you start taking parts of that foot away, what's left can be a real challenge for us sometimes. And we're going to actually look at some examples of that. Amputation is not an admission of failure. And to be honest, when I started, I've been doing this for almost 50 years now, 51 years. If somebody had to have surgery, I felt like it was such a letdown. I didn't want anybody to have surgery. Well, get over that crap. Any of the surgery with the foot, well, I won't say always, but very often a surgical procedure on a foot, even with an amputation, can make our job a lot easier. If they're going to have surgery, most of the time they still need us as podorthists, orthotists, or prosthetists. So it really is an admission of failure. And it really may be the first step to returning that patient to a productive life. Diabetes is the leading cause of amputations in the United States. Obviously, we all know that stuff. I'm not going to focus just on diabetes here. We're going to talk about a lot of different things. But we all know, and we'll explore some different causes for amputation. Peripheral neuropathy, of course, is a major contributor. We see a lot of peripheral neuropathy in diabetes. That isn't necessarily a diabetic thing. But we've got, and I think when we talk about peripheral neuropathy, some people focus entirely on the sensory thing. And obviously that's an important thing. I think our patients, they relate very often the sensory issues to the peripheral neuropathy. But always remember, it isn't just protective sensation, loss of sensation, impaired sensation. It's also loss or alteration of the motor function and the autonomic system. And so a lot of stuff's going on with peripheral neuropathy, and I'm sure you do, but I spend some time talking to my patients about that on occasion. So, their foot may not function the way it was supposed to. That's why their feet are dry. Maybe that's why there's increased blood flow. So all those different things take place with peripheral neuropathy. It's not just sensory issues. Obviously, the biggest cause, as I said, was diabetic, with the diabetic patients, diabetic neuropathy. But we can have neuropathy of so many other etiologies. And Charcot-Marie tooth is a big one. Rheumatoid arthritis, Hansen's disease. We don't see a lot of Hansen's disease here, but it's still around in many parts of the world. A lot of low-resource countries. Spina bifida, spinal cord injuries. Here in Wisconsin, with our beer and our brandy, I have seen quite a few people with peripheral neuropathy, loss of sensation due to alcoholism, exposure to heavy metals and certain chemicals, and then idiopathic neuropathy. I just am seeing more and more of that. I have so many patients that are coming in with significant peripheral neuropathy, the consequences of that, and they have no idea, and they've gone through tests and everything else, and the physician's medical field does not know why they have the peripheral neuropathy. I just had a guy that had a midfoot fusion done, not a real good fusion, for a midfoot Charcot, and to this day they don't know why he has the peripheral neuropathy, but he's got all the effects of what we expect to see in a diabetes patient. Vascular disease, and that just complicates our issues. We've got the peripheral neuropathies, and then we've got some vascular issues. And a lot of times people don't really realize that they've got a vascular issue. But I've learned early on and see it all the time that people can have very, very poor vascularity, very poor blood flow, but the foot can be maintained. But once they get that infection, or some portal of entry for that infection, there's not enough blood flow to fight that infection off. So vascular issues are a major consideration when we're looking at these patients. Think about trauma and burns. I think so many of us see so many diabetes patients. I think as pedorthists probably, we see a lot of different types of amputations within our diabetes patients. So there's insensate foot. But if it's trauma, it's a normal foot that has an amputation, depending on what type of amputation, what type of surgical procedure was done. You can have hypersensitivity. It's real easy. I guess you could say it's easy with the diabetes patients or the insensate foot. We don't have to worry about it. They can't really complain, but obviously that's what makes it so much riskier to work with those patients. But if you've got a patient that has hypersensitivity as a result of trauma, amputation, whatever, those are really tough because those people sometimes can't even stand to have you breathe on their foot, let alone apply any kind of a device to fill up the shoe and maintain position of the foot. So you don't always think every amputation is going to be insensate. Look at frostbite and gangrene, obviously, can be a major issue. And that can be just because people are outside for too long to get frostbite. But then we go back to the insensate foot. You can see a lot of frostbite because they can't appreciate the fact that their foot is that cold. What necessitates an amputation? I'll go through this quickly because it's certainly something that I think we understand. But I talked about the peripheral neuropathy and some sort of loss of protective sensation. And that loss of sensation can be in so many different ways. You end up with a wound or an ulcer. And then the next thing we talk about is poor circulation. And I think there are a lot of people, in fact, I've been on the podium. I remember one time I was on the podium with a vascular surgeon, and she said, the reason these diabetics have all these amputations is because their circulation is so bad. I don't really buy into that. It's a big complication. It certainly causes amputations, but within our diabetes population anyway, it's a loss of protective sensation. That in so often is what causes the initial ulceration or wound. Poor circulation, and then obviously an infection, and eventually osteomyelitis. And usually if there's osteomyelitis, the bone is involved, that bone is going to have to go away. So factors determining the level of the amputation, obviously extent of the infection. As I just said, if there's osteomyelitis, there's infected bone, that bone's usually has to go. And then vascular status has to come into play as well. You're not going to do an amputation if there's not enough blood flow there to heal that incision or that repair of the amputation. And I'm not picking on vascular surgeons. I don't know who isn't really in our audience. And we've got, so many different disciplines taking care of feet. And I'm not at all being negative about a vascular surgeon, but I do see some of the more challenging feet that I see are from people that are focused on the vascular issues primarily, and not really understanding the functional or the biomechanics of the foot and what can happen. And I think we're all guilty of that. We use the tools that we have available to us. I'm going to use all my pedorthic tools as far as I can. And then when I can't take care of the problem anymore, it goes to the prosthetist or the orthotist. And I think that sometimes when we focus just on the vascular and the infection, that's when we get into trouble with some really crazy looking feet that are very, very difficult for us to try and manage and maintain after the amputation. If you're just going to look at where is there enough blood to heal the ulcer, or I'm just going to take away the part of the foot that's infected, very often we don't end up with a functional amputation. So it's really, really important that whoever's doing the amputations understands the function and biomechanics of the foot so that we have something we can manage appropriately. Transmetatarsal amputations, and we just look at some indications here. Forefoot soft tissue or loss due to gangrene, infection, maybe a thermal issue, and here you look at this picture. It looks like the fifth toe isn't really involved. It's hard to say, but the challenge or the temptation might be, well, just to get rid of those, 1 through 4. Well, if you look at the quality of the skin, up behind you, the distal part of the metatarsals, compared to the farther back in the foot, I think we in our old selves know that there's something going on up in this forefoot. So just to take those toes off may not be a real good amputation, because the rest of this may not survive. So this probably is a candidate for a transmetatarsal amputation. Here we've got somebody that lost a couple toes already, and now they've got osteomyelitis in the third toe. And obviously these kind of things happen. I mean, we sort of chase things if we're not, I think, especially if we're not managing them appropriately. And I'm probably going to say this 2 or 3 times, but if we get rid of this third toe now, and we leave this first and second just dangling out there in midair, there's a good chance, unless they got some really super duper management, orthotic and prosthetic management, that they're going to end up with ulcers on those as well. So this would probably be a real good candidate for a transmet, and then that's something that we can manage pretty appropriately. Having those just leaving a couple toes like that can be really tough to manage sometimes. This is a mess, and this was actually a crush injury. I think this young lady, the forklift ran over her foot. And I'm embarrassed to say this was at the medical college ER. She went in, and they threw all these pins in there, I guess, to try and think they're going to save the forefoot. It didn't take long at all for those toes to all be dead, and you can see they're gone. And she came to, this was when I spent a lot of time out at the medical college with the crew out there. We had a wonderful fellowship. And they did a transmet amp, and then she had a little bit of an ulceration down here. But they did the transmet. We got this closed. And this is a young, vibrant young lady. I mean, very, very healthy. She was back to work within months. I mean, everything went so quickly, and she healed so well. But, and maybe in some facilities that would be a total amputation of that foot. But she had a very, very functional foot after she was properly cared for. And then tumors. And the only reason I'm throwing these things out at you here is I've had the advantage of all the years that I've been doing this, of working with some of the best foot and ankle people, I'd say, in the world, certainly in the country, and working with them side by side. And so I see a lot of the reasons for a lot of the amputations and surgeries that are performed. Some of you may not have that opportunity. So that's why I just thought it's sort of important to sort of throw some of this stuff at you. With this, you've got, again, certainly 2 and 3 have the tumors at this stage of the game. So what would you do? Just do a second and third toe amputation, maybe part of partial metatarsal or something, but that probably isn't appropriate, because a lot of those tumors have tentacles or roots going out from those tumors. I always think I sort of relate it to when I'm pulling weeds in the garden, and you take a piece of crabgrass, and you pull it up, and you've got a whole string of crabgrass all the way down the garden, and they just keep growing and growing, and that's what can happen with some of these. I'm not a doctor, but I've learned enough to be dangerous with these types of things. If you aren't aggressive enough, and you leave some of the if you will, roots or whatever, tentacles of that tumor, they come back with vengeance. And I've seen that when I've been in clinic, where people have done minimal surgeries on those and just remove the tumors. And the result of that can be unbelievable. So again, that's looks like the best bet might be to do a transmetatarsal amp on that. That's an issue with people, and we have to understand where the doctors are coming from too, because when someone's going to have an amputation, they've got to agree to the surgical procedure and the result of it. And I've seen many times when people just plain refuse to let the doctor have that freedom to do what he really thinks is necessary. A lot of people don't want to lose any more of their foot than they have to, and that's understandable. But you can see a lot of these reasons that we're just looking at here, that transmet is a very, very good option for many of the situations that we see, even though it seems that there's some viable part of their foot that they're actually taking off. All right, so that was just talking about amps basically are reasons for amputations. Then we look at metatarsal phalangeal joint, and it just could be just a great toe, or all or partial part of the toes, and it can be a challenge for us. I don't think it affects their gait overwhelmingly. Personally, I don't think it does. Amputation of the great toe, and if it's just the toe alone, I don't think it's going to affect gait terribly because they still have that first metatarsal shaft, but it unbelievably transfers pressure over to the other metatarsals. Amputation of the second toe, the great toe is going to drift into valgus. Amputation of the lesser toes doesn't usually alter the gait too much. So, transmetatarsal amputation, I talked about that briefly already with the indications. When we look at transmetatarsal amp, you can have different levels there too. So I mean, it's a transmet. We're cutting it through the metatarsal shafts, but that can be a long or a short, and you can have a very different foot depending on where that amputation was done. And obviously, a little bit more length is going to be better. It's going to give that foot a little bit more stability. Typically, and again, I'm not the surgeon, but if they're doing that amputation, you want to have pretty much follow the cascade of those metatarsal heads before. The concept would be that would be the most functional crescent or shape of that amputation to sort of follow the function of the foot prior to the amputations. Now we look at some pitfalls, and here we can see there was inadequate resection of the diseased tissue, and I think we all have to appreciate what the doctor's goal is when they're doing the transmet amp. They would like to bring as much plantar skin up over the end of the foot as possible. If we've got a lot of plantar skin, the plantar skin's got to be the toughest skin we've got on our entire body. And if we can bring some of that up over the end, that distal end of that amputation is going to be a lot tougher, a lot more durable. And maybe that's what they were trying to do here. I'm not just sure what they were trying to do here at all. This is all of the pictures you're seeing are my patients, but I didn't see this patient at this stage of the game. I don't know what they were planning on doing here. So they obviously had to go back in if there's infection there. And the person ended up with a very short transmet when they were done with it. Uneven cascade of the metatarsals. We saw that X-ray when we saw the cascade of the metatarsals with that X-ray. Here you can see they're just sort of all over the place, and of course how that amputation is done, probably the way that bone is cut could even make a difference. So here you can see that the metatarsals heads actually work their way out of the bottom of the foot. I think we all recognize that didn't happen yesterday. So we know by looking at this picture that's an insensate foot, and those ulcers have been there for a long time. With that much callus around them, those have been there a long time. So that's obviously one of the issues that we obviously see with our insensate feet. And so many people are not looking at their feet. I just actually had a lady, I just actually moved my office to my hometown, and after I got here, I had a lady come in, and she was wearing a plastic AFO. She was frustrated with anybody and everybody in the world, her orthotist and all the podiatrists she'd gone to, and she was working with a PT, and she was wearing a solid ankle AFO. And the therapist she was working with a physical therapist, and he was trying to get her to improve her gait, and he was padding in between her diabetic insert that was inside of her AFO, and he was trying to wedge inside of there to correct her gait. I'm not just sure how that was going to work, but that's what he was doing. And the lady had lymphedema from her waist down and was not real mobile. And I took her shoe off, I took the brace off, her sock, and she had an ulcer that looked pretty much like one of these, the bigger one. And I told her, I said, you've actually got an ulcer on your foot. She had no clue. So we provide such a service with so many of these patients, and I only tell that story because I'm looking at this picture, and she had her entire foot, but she had an ulcer under one of her metatarsal heads. So that's how they get into so much trouble, and they're just not paying attention. Okay, this goes back to what I was saying before. Here, I'm not sure why you would leave that first metatarsal, the entire first metatarsal shaft, but I'm not a surgeon. But you leave that sort of thing sort of dangling out there, and that just sets the stage for reoccurrent ulcerations on there. And we can do all kinds of things with different types of foot orthoses, rocker soles, shoe modifications, but it still is hard to manage that when they're pushing off with the end of their first metatarsal. And I see that a lot. Here, leaving these couple toes dangling over here. And again, I know for a fact that oftentimes that's, again, because the patient doesn't want the doctor to take any more than is necessary. So you've got these two toes, and right after the surgery, there's some structure there, but I find from over time, they end up being very flaccid, there's no control whatsoever. It's hard to put a sock on. And so really, in my mind, it would be a good transmet right off the bat. And then here you can see a callus up here at the end. And I don't know if that's from the end of the first metatarsal or one of these sesamoids moving around. So they lobbed off the head of the first, but left the sesamoids there. So and I'm not, it's easy for me to criticize, but and I don't mean to be be overcritical, but these are the things that we get, and we've got to try and manage them, and they can be really a challenge. When we would have just done a transmet here, that would be so easy for us to manage. Okay, and then the preoperative Aquinas contracture, and I've been doing this for so long, years and years. Nobody recognized that. And I tell you, it was a challenge. We would get these transmetatarsal amps and have distal ulcerations. And it was almost impossible to offload something like that because that foot was in so much Aquinas. It was plantar flex so far. And it was very difficult to manage. Today, I would have to think most of the people, I hope that most of the people that are doing these types of amputations recognize that there is an Aquinas contracture that may have contributed to the forefoot ulcerations that precipitated the transmetatarsal amputation. Simple gastroc Achilles lengthening makes that foot nice and flexible and so easy for us to manage. So, but I tell you, if you're not used to, if you've never seen this, it's really bad, and it only makes sense if you're going to cut off the half of the foot, the forefoot off. A lot of the plantar flexors our dorsiflexors are gone, but that Achilles tendon is still pulling real strong, and it goes down into Aquinas. So hopefully we aren't seeing too many of those anymore. Okay, then other types of amputations, a tarsal metatarsal or the Lisfranc amputation. Now, one of the changes that we did make to the ABC code of scope of practice when I was on the board, I was on the board for 12 years. One of the things was that in the pedorthic scope of practice, it was very vague initially, and in the ABC scope of practice anyway, is we're able to take care of transmetatarsal and more distal amputation. So anything more proximal, which would include a tarsal metatarsal or Lisfranc amputation, really isn't in the pedorthic scope of practice. And I think early on I used to try and play with those, but very honestly, I'm at a point in my career and really, I guess from knowledge, that doesn't really belong to me. Maybe I don't have the right skills, right? Show part belongs with our prosthetist friends and certainly assigned. So those are things that are out of our scope of practice, and I think in my mind, there's plenty for us to take care of within our scope of practice. But one other thing that is in our scope of practice, and it's really, I would say it's sort of an amputation. It would be a partial or total calcanectomy, and that would be in our scope of practice, and these can be challenging. Here we can see it with a partial, without any tissue loss here. So that was actually an easier one to take care of. This device, I'll talk about it in a minute. It was something that we had developed here in Milwaukee when John Gould and Mike Sheriff and Jeff Johnson were here, and Dr. Gould liked doing microsurgery and skin grafts, and he had a hand surgeon that was working with him, and so we were seeing a lot of these types of things where they actually would lose the entire fat pad, a good share of the skin on the heel, and they would actually put muscle flaps on with a skin graft over it, split skin graft over it, and that's a cool idea because it put the muscle there, so it provides cushioning. The problem is that muscle isn't attached to anything. It's only attached around the perimeter of the flap and the skin graft. So you can take that big piece of muscle and just move it from side to side. So it really was a challenge, and there were just so many of them being done at a 2 or 3 year period. And finally, Dr. Gould came to me and said, "What are we going to do with this?" Because they would put them into a regular foot orthotic into a shoe, and it would slide off. It would break down. It became a really big problem. And then you can see here in this one, you've got two screws in there too. So you've got metal in there that could easily work its way out of this muscle and skin as well. So it was really a big problem. How do you contain that? It's put there for cushioning, but how are we going to contain it and keep it in place so that it provides the cushioning? So we developed something, we called it a hindfoot containment orthosis. And it's really an archaic way of making this thing, but I think it still is probably the best way to make it. We would take a cast, but actually like a cast you were taking for a custom shoe or something, and we're going to make the device as high as the scar tissue or as high as that scar tissue is out of the shoe. So, I mean, some of them have to be really pretty high profile. So we'd use take that cast, and I still do it with some of the devices that I'm making now. I'm still a big fan. I mean, everybody's into EVA. I still am a plastizote guy for a lot of different situations. And if you use number 2 plastizote, basically the white plastizote, or it could be different colors, but the number 2 plastizote is firm. It has some shape. It will hold some shape. But if you heat that to just the right temperature and vacuum form it or pull it over a cast, the outside of it, you may have some wrinkles, but on the inside, it will be actually totally smooth. It's like that plastizote just bonds to itself. So here you can see how high we made the heel cup, or the profile of that hindfoot containment orthosis. But we did it with that number 2 plastizote, and the inside of it is totally smooth. Then you put it on top of the cast again, build a dam. You can see the dam that we have right here. And then I'm also a big advocate still of PQ, viscoelastic polymer. And you see there's a deficit here. It's a skin graft. I'll go back here a minute. You've got this muscle and skin graft here. Right. So we want to replace the part of the foot that was missing. That's what we're doing. And so we use a soft viscoelastic polymer. Now, when you use it real soft, you've got to contain it because it will displace. But I want to use it to fill in the void that was created with the amputation or the calcaneal fracture. So we use a real soft viscoelastic polymer, and then we actually wrap that with fiberglass tape. And this is the crazy part. And then use an ace bandage to hold it in place. Now, why do we vacuum form it? If you vacuum form that soft viscoelastic polymer, it would just splay out. So we have to keep that in place. So we wrap it with the fiberglass, let that set, and then trim it to go into the shoe. And here you can see the top lines. The viscoelastic polymer is right here. You can post the bottom of it if you want to, and then it goes into the shoe. And we actually did a study on that, and it really worked well. When you took that device, you actually had to wiggle it onto the foot because it fit that tight. But it had to fit that tight so that it kept the muscle flap on the bottom of the foot under the calcaneus. In our study that we did, people had to have them replaced in the first year because what happens to muscle if you don't use it? It atrophies. And so if the muscle flap atrophies too much, moves around too much inside of that HCO, the hindfoot containment orthosis, then you would get breakdown again. So in the first year, we sometimes had to replace it 3 or 4 times as that foot atrophied, as that muscle flap went down. And then at the end of that, the foot was relatively normal size, and you could get this device into a depth type shoe. Okay, pedorthic objectives. Obviously, we have to get the pedorthic. Improve gait, restore functional gait, provide a filler for the amputated foot. There are a lot of different people, different concepts, I guess, out there on what that filler does. I'll talk a little bit more about it later, but I'm going to talk some now. That filler, in my mind, is to maintain the shape of the shoe. That filler is not there to hold the foot in place. A lot of your patients will feel that way. They'll feel like, well, I've got to put the filler in so my heel doesn't slip. Well, that's not how you keep the heel of the shoe from slipping on the heel. That filler is there to fill up the shoe, and that's an important reason, because if you don't have that filler up there, the shoe will crease and very often cause breakdown on the dorsal aspect of what's left of that foot, and I've seen that happen many times. Excuse me. Equalize weight-bearing pressures. Obviously, if we lose any part of the foot, 26 bones in the foot, all that fun stuff, if you lose any part of it, the foot's not going to function properly, and the weight-bearing will be messed up, and that could contribute to reoccurrent or new ulceration. Protect and accommodate the remaining foot. Contain the foot in the shoe, which is very important. If you get to those, even with a real short transmet, keeping it in the shoe can be a challenge sometimes. And decrease shear and friction. So this is all stuff you know, or at least have knowledge of. But partial foot socks, I'm really an advocate of that. A lot of the companies have now gone to providing a partial foot sock, a short sock. And that's really important, because the people that are giving us a partial foot sock recognize that we can't have a big bulky seam at the end of that foot. I find a lot of people would get tube socks, just a cheap tube sock with a big old seam, and they take that sock off, and you can see that the impression of the seam in the remaining foot in the Transmet amp. So it's important to have no seams, and it's really nice to have a sock that fits their foot so that their heel isn't halfway up their leg. We've got socks that are great. They've got silicone distally to cushion and decrease shear at the end of the foot. There's a glide wear material that it came from Tamarack, the company that makes Shear Band, so those types of things are really advantageous to have for the patient. And the silicone sock, something that will decrease the shear at the end of the foot, is so valuable. They're expensive, but once somebody has tried them, they treat them like gold. They take very good care of them because they're so expensive, but they wouldn't want to leave home without them. Okay, shoes, soft moldable uppers. Obviously, in many cases, is going to be preferable, because we've got to be concerned about the remaining foot. A high top shoe, though it's harder and harder to find high tops. I mean, when I started, we had high top court shoes, and that was what we used for a lot of our Transmet amps or any type of an amputation, because the foot was shorter. Even the athletic shoe companies have gotten away from a lot of the high top shoes. Blucher opening, obviously, is I like a Blucher opening or a modified Balmoral opening, so we've got adjustability, so we can really get control of that foot. Just watching my time here. Custom shoe if necessary, and you may get some really, really crazy feet that are just really hard to accommodate in a regular shoe. I don't go to custom shoes very often. A short shoe versus a regular shoe. I mean, obviously, and I'm sure you hear it, if somebody does have all of their toes amputated, they want a shorter shoe. Well, they've got all of their metatarsals. Shoe Fitting 101 says they don't get a short shoe. They still get the same size shoe, because we have to put the widest part of the foot in the widest part of the shoe. if they've had a transmet, maybe say a long transmetatarsal or just a partial, some of the metatarsals are still, some are gone, you can go to a shorter shoe. But always remember, if they wore a 10D and you're going to fit them with a size 6 shoe, a size 6D is going to be way too narrow. So it isn't as simple as just taking the size the size and width they had and shortening it up. So it's not as easy as it sounds. Now here, this is a real extreme on a short shoe. This is a fella that had an amputation. It looks a little rough, but it actually is quite functional. And I've done this. I don't do this often, but on rare occasions, I make a real short shoe. That meaning a shoe that just fits his foot. And I know if I've got any prosthetists in the audience, you would tell me that it's ridiculous because it's not going to function properly. There's nothing for push-off. But there are people that just really do better in something like this than a brace, a carbon fiber, anything, a shoe with an extended steel shank and a rocker sole. This guy does fantastic with it. He tried a lot of different things, and then he came to us and basically wanted a shoe the size of his foot. So we make it black, and any shoe that he wears on the other side is black, and as far as he's concerned, they fit. Now, you can say functionally that doesn't make sense, Dennis. This guy's a Milwaukee policeman. He's a patrolman, so he's on his feet all the time, probably chasing criminals with that one little short foot. So there's exceptions to every rule. Shoe modifications. Rocker soles, obviously. Very often we're going to be using the rocker sole to protect the remaining foot, to help with toe off, to help propel, basically replacing the forefoot of that that's missing. Shank, you can use either steel, carbon, or carbon fiber. I personally still like spring steel. It's easier for me to use. The carbon fiber, obviously, there's types of carbon fiber that people will use too. It's just, I find the steel so much easier to bend and mold and get into the shoe. And that's a pretty important part of that rocker sole for the people that have had transmitted or more proximal amputations. Okay, flares, obviously, medial and or lateral flares. I think with our a lot of our transmets, if the cause was that Aquinas deformity, that doesn't all go away. So a shoe with a lateral flare, I think you're going to use more lateral flares than medial with our amputations, but some may be tilting or going medial as well. But the flares are very, very helpful. Satch heel. I still do a lot of satch heels, and the satch really, is great because it provides shock absorption on heel strike. Remember, the foot is the shock absorber for the whole body, and if a lot of that foot is gone, that foot's not absorbing shock as well. So the satch heel can really come in handy for some of these people. Added collar, extended collar, and this is a sort of a crazy modification, but I call this my quasi high top shoe because for one, as I said before, we can't always get high top shoes when we want them. And, for a lot of our people, I've had a lot of people that have had transmets and they do fine with Oxfords, but depending on their job or their recreation, I can think of a lot of people that did well with a shoe, but they wanted to do gardening in their athletic shoes, and they go out in the garden. And of course, the heel, when they bent down, they were kneeling on the ground all the time. The shoe was popping off. So this is, again, making use of my number 2 Plastizote. And I just actually put Plastizote on the top of the counter, cement it, and then use a leather and just cover the leather. And you can see in the picture, or if you can see my example, it's really sort of over exaggerated to capture the foot. But remember, there's Plastizote inside of there. It will mold to the foot, or you can heat it up a little bit and mold it to the foot that's coming out, the Achilles area and everything else. You can just mold it to fit, and it's going to really be very much like a high top shoe. And relasting, if you've got a lot of, I'm not going to get into the relasting here, but if you've got a lot of deformity, you can relast or reshape the shoe to fit the shape of the remaining foot. Okay, so when we look at foot orthoses, when a lot of people will use carbon fiber plates instead of the extended steel shanks for the same purpose, to provide push-off, to make the shoe rigid, to decrease. I mean, with our transmetatarsal amps, we don't want that shoe flexing too much, or you could actually cause a lot of friction, a lot of pressure on the distal end of what's left of the foot. And again, this is my preference, and I'm doing the talk, so I'll give you my preference. If I've got an insensate foot, I would like to do an extended steel shank in the shoe so that I have some degree of control of what that person's wearing as far as a shoe. If it's somebody with a totally sensate foot, the sky's the limit. I will put the carbon fiber plate on the toe filler, but I don't like to do it for my diabetes patients, because if they take that device and put it in a shoe that doesn't have enough toe rock built into it, it'll very quickly cause problems and potentially break down on the foot. So they both can accomplish the same end. When it comes to the steel shank, I've actually had physicians that obviously did not work with a good podorthist and say that I don't like to use steel shanks because they work their way out of the bottom of the shoe and it's dangerous. Well, when you're putting a shank in the shoe, I knock on wood, I don't think I've ever had one work its way out of the outsole or the insole. You've got to shape that shank to fit the shape of the foot. If you just put a flat piece of spring steel in the bottom of, a straight piece of steel in the shoe and then try and put a sole around it, yeah, it's going to work its way out. But when you do that, shape your shank to fit into the shoe. You can make a trough, or you can enclose it in between two pieces of EVA, but shape it to fit the shoe and cement it in place. If you use some real, rough grit sandpaper, you can rough this steel up and you can cement it in place, and it will stay. So I'm a big advocate of the steel shanks. Obviously, it makes it strong, the shoe heavier than the carbon fiber would. Okay, when we're making our foot orthoses for especially here, I'm gonna talk about the insensate foot. I like to use #1 plastisode, and it's sort of funny. A quick story. I did this at an AOPA meeting once, and I said I like to put 1/8 of an inch of pink plastisode on top of my orthoses for anything I'm doing for a diabetes patient or an insensate foot. And somebody stood up and said, I don't know why you use that crap. It bottoms out right away. I said, well, I use that crap because it bottoms out right away. And really, that's with the insensate foot. You're taking a static impression of that foot, or you're scanning it, or whatever you're doing, but that's static. It's not dynamic. And that 1/8 of an inch of plastisode will take on the last shape of the foot, and it really, honestly, is so important to get that final fit. And it works great as a dynamic floor reaction imprint as well, because they can come back in a week. If you were trying to offload a metatarsal head and you take it out of the shoe and the plastisode is totally bottomed out under that prominent metatarsal head that you tried to relieve, then your posting wasn't appropriate, because it shouldn't have bottomed that out. It probably should be 1/8 of an inch yet. So those are my two reasons. It takes on the last fit, and like I say, it's like a dynamic floor reaction imprint. So that crap really works. I think it's a valuable tool. Here we talk about what are we going to do with what's left of, for the filler portion. I don't get crazy with something fancy out there. Usually I'm just going to use some plastisode or EVA foam. I don't need anything fancy out there. It's just there to maintain the shape of the shoe so that shoe doesn't crease up. Again, we don't want the foot banging up against the end of this. My concept is you want this filler to fit like you fit a shoe. You need some room between the end of the foot and this filler. Even if you put a shank in that shoe, it's going to bend some. And if it bends any at all, it's going to be banging up against what's left of the foot. So it stays in the heel with the way the shoe closes, not banging up against this. Now, Roger Marzano, I don't know if he still does it, but Roger had his lab make this all a multitude of different colors. And it was very, very pretty, but in my mind, it was very time consuming. So that's one thing I didn't copy from Roger. You can intrinsically post, but always be careful with I think especially the insensate foot, intrinsic posting isn't the easiest thing to change. And a lot of the feet that you're looking at, even with with our amputations, that foot can change. And if you've intrinsically posted something and the foot changes, that can cause a problem. I like extrinsically post. Then if the foot changes, it's so much easier to adjust. And if we've got something for the stump, again, don't get crazy with different kinds of fancy materials. Now here, this is a lady that had a bunion surgery, believe it or not, and this is what she ended up with after a bunion surgery. I've got a little bit of a different practice now, and I'm getting a lot of post-op stuff, and this lady was an absolute disaster. She had lost 2 and 3. This very little motion in this first, and it was starting to drift. And she actually wanted something to push the great toe. She wanted something to push this toe and keep it straight, the great toe. Well, obviously there was no way that was going to happen. And she couldn't tolerate it anyway because she was in so much pain. It was a terrible, terrible result of the surgery. But we do use the pediplast or whatever material you want to use. It's sort of like a silly putty type thing to do something with an interdigital amputation. Those are tough to deal with. If it's 1 and 2, 4 or 5, but when it's an interdigital, it's nice to be able to put something in there to keep it, because the toes will drift. They'll drift and they'll close. The toes will go any direction. If there's space, they're going to fill in. And so you want to try and keep them in a proper position. But if you just put a toe spacer in there, you run the risk of it migrating or ending up under the foot. And I've seen cases where people did that with a rubber toe spacer, and people walked on it for a day and they had a new ulceration. So here, when you're doing something like this, you want to bring it up around the neighboring toes so that there's some way of keeping it in place. And then the Shear Band. I'm a one-man advertisement for Shear Band, but it's really the only thing that's out there to my knowledge. Shear Band is a wonderful material to decrease friction and shear. And so many of the problems that we're seeing on a lot of these feet are due to friction and shear. We're obsessed with pressure, and obviously we can measure pressure. We can identify pressure. The shear and the friction is not as easy to identify. You can sort of come to predict it with an amputated foot, post-ulcerated foot, any of the scar tissue that's there. I put a shear band on. I will apply shear band to the foot orthosis right off the bat, because that's anything that's scar tissue. It's not going to be mobile skin anymore, and it's scar tissue, so it's going to break down really easily. So I know I've come to learn where I'm going to need the shear band, and it's very expensive, understandably. But if you use a little bit of shear band, you may avoid a reulceration or callus buildup, and you're probably going to avoid some follow-up visits. And not that we want to take care of our patients, but if this would avoid somebody coming back for because they're getting a lot of callusing or breakdown, I think it's worth a little bit of money to use the shear band proactively rather than waiting till there's a problem. Because if you use it enough, you'll understand where you need to be using it. It's a wonderful material. Partial foot AFOs. Obviously, this was developed by Ernesto Castro, the Arizona type brace, and then obviously it was made into a toe filler type thing. Great for those really, really short amputations. And then this is something else it's actually a Meso partial foot. This is something that my sons and I came up with. It started out as just a hindfoot brace, and then we went and made it into a partial foot device. This is available at it's actually licensed to Arizona Brace, so the only place you can get it is from Arizona at this stage of the game. But and I shouldn't be talking brand names, but that's the only place I think that you can get something like this. But what's nice about it for those, I use it for transmets all the time, but for the shorter amputations, it's even better because you can lace the foot in there and keep it in place. A nice thing about it is that the filler part of it actually comes out. So there's a life expectancy for this device, but if you have to replace the inside, you can just bill for this, or the patient can pay for it. Also, if you need to modify it, this can be taken out and be modified. It's hard to do anything inside of a device if it's all one piece. So this has worked out pretty nice for a lot of my patients. I just saw one fella that he was doing the toe filler and boot thing for a long time, and we came out with this, and he's in his 60s, but he's still fishing and hunting with his boys. He's still working a full-time job. This changed his life because it controlled his foot and kept it in place. Follow up. Here you can see we've got an issue of a new ulceration, and that ulceration is from that crap plastisode that wore out. Obviously, that there is wear and tear on any of the devices that we're making. So I'm an advocate of follow up, and as often as possible. With my diabetic or neuropathic feet, I send them reminder cards. I wouldn't tell you, I'd be lying if I said I have real good follow up from it, but I would like my folks to come back every 6 months to look at the device. Is it wearing out? If this lady would have been back to see me, we wouldn't have had this issue. She wouldn't have had that new ulceration. The shoe may be wearing, a lot of different things. And again, always say the foot may have changed. So with the diabetic neuropathic foot, they don't have good sensation. It would be great if we could get them back every 6 months. With my traumatic amps, I'm not worried about it. They're going to know when they need to come back. I recently had Kathy, one of my podorthists, was seeing somebody, and I looked at her schedule, and I saw a name, and I recognized the name, and it was I started with him, it's probably 20 years maybe or more, and he's been with us through that whole time. His dad ran over his foot with the lawnmower, and he ended up, that was one of those deals where he begged the doctor, the dad begged the doctor. He was I think 4 or 5. The doctor begged the doctor not to take any more than he had to. So he had 4 and 5 left. And so I took care of him initially. Then he actually was being seen in our Madison office for a while when he went to college, and then he was back in Milwaukee, and Kathy was seeing him. And I saw the name, and I thought, that can't be. And I walked in, and he had his shoes and socks off, and I introduced myself. He knew who I was, and I said, it's so great to see you. And he says, yeah. He says, I said, what's going on? He's got his own children now. But anyway, I looked down at his foot, and those 2 toes were gone. I said, what happened to 4 and 5? He says, Dad wouldn't let me have those taken off. So he said, when I was in college and I was of age, he said, I had my foot revamped, and he had a real nice Transmet amp. He had it done himself. So leaving those 2 toes hanging there really don't mean a lot. But at any rate, where I was going with it, he had his foot orthosis, and he had under the first metatarsal, you could see through it. You could put his finger through the foot orthosis. So he picked it up. He said, I guess I waited a little bit too long. I said, yeah, I think. But he has sensation. So he wasn't at risk of ulceration. And he's a very healthy young fella. So for the traumatics, I encourage them to come back once a year or as needed. I don't require them. I'm not sending them reminders. I think we can be pretty sure that they're going to be back to see us. All right. And I'm 2 minutes over. Not too bad. I hope everybody enjoyed that. And we have some questions. We can go there.
That was awesome. Stop sharing the screen, Dennis.
How do I stop sharing? Okay. I'm not real technically sound. A lot of you know that, so Rich has to help me with this stuff.
Nice job. Great presentation. Obviously getting a lot of claps. A lot of people liked it.
I got to go back and okay, there I am. Cool. All right. Well, thanks everybody.
Hey, Chris, nice to see you, buddy. You're using Pettyplast there. You saw that in the presentation. Listen, I'm sure there's some questions. We'd love to get them all in. Thank you, Nikki. Obviously, everybody's saying thank you. Great presentation.
Thank you. Thank you.
Yeah, for sure. Glad you're all here.
I look forward to seeing everybody in person next year. All right.
Absolutely. So who's going to be the first one to grab the mic and come up to the stage and at least say hello? Is Roger still here? Roger should be grabbing the mic.
Roger goes to bed early. He's a win.
True. He does. Oh, here he is.
Ah, there he is.
That's what's up.
What's going on, old man?
Hey, he's coming up. There he is.
Oh, that picture. Now that's really him. That picture was not him. That was how long ago?
Hey, watch it.
Hey, Roger. How are you, buddy?
Good to see you guys. That was excellent.
Good.
Awesome.
Glad you're here, Roger.
Hey, we're glad to support you.
I learned a lot of stuff from Roger Marzano. Roger and I, we had our own tag team for a long time. I took him to Taiwan with me one time, and that was dangerous. I think we almost got put in jail one night, but we had a lot of fun in Taiwan together.
I bet you did. I'm glad I wasn't there with you guys.
You know what's amazing is no matter how far down the road we get and how many partial foot amputations you take care of, it's still ever evolving. And the thing that really is the biggest factor is the patient themselves. You know, you can build the best device, but as you know, compliance is an issue. Taking care of these products is an issue. Medicare saying those things should last 5 years on an active amputee is an issue. And we're getting the snot beat out of us. Aetna pays me $225 for an appliance like that. And you're married to these patients. So, you know, it's the people. It's no different than the diabetics that we take care of, that we lose our shirts on every day. And yet you try to do the best job. So it's nice to see, Dennis, that you're doing the same things over and over, just like I am. And it doesn't matter. The materials change, but the common denominator is the human being.
Yeah. And it's like you say, everybody is individual. You can't approach any of this stuff with a textbook and say this is supposed to work. You know,
nope. That was a great job.
Yeah, thank you, Roger.
You did wonderful.
Hey, good to see you. All right, who else? Mike. Who's next to grab the mic? I know somebody else is going to come up and hang with us for a minute. All right. Here we go. We got house set. All right. Somebody else is going to come up.
I see something on the bottom. It says cocktail party.
Yeah. Hello, house set.
Hi. I'm very glad to see Dennis and Roger back into PFA, and because they were away for quite some time.
Oh, they ran me out. I'm coming back whether they want me or not.
No, we can't let you go.
I'm not going anywhere.
And Roger too. Roger Marzano is a great guy too.
You betcha.
Absolutely.
We really appreciate your presentation. I've seen it quite a few times, and I really like it. And I like the shoe modifications that you do too.
And shoe modifications are so important, because if you're just going to do it with orthotic devices, you're not going to give them the proper care. The shoe modifications have to be a part. The shoe has to be a part of it, and the modification has to be there too. Otherwise, you're not providing pedorthic care.
I'll do ton of shoe modifications.
Yeah, exactly. And some days I do more of that. I've actually got, I've downsized, and I'm doing a lot of my own work now. And the shoe modifications, I moved out of Milwaukee. I'm in our hometown now, and people are driving hours to come and bring their shoes to me, because it's sort of a lost art. There are a lot of people out there that aren't doing it.
Dennis, what I shied away from, especially with double rocker soles, I don't do it much anymore. Those double rocker soles, I don't think they're effective.
The research showed that they were. I mean, I still use them, but it all depends on the patient. All depends on the patient.
Very individualized for sure.
Yep.
Yeah, I do negative rocker, I do forefoot rocker, I do midfoot rocker, but those double rockers, it wasn't working very well for me.
Yeah, I have my sample here.
Yeah. I mean, let me ask you a question. At one time, they did a study with a rocker sole, with 3 different rocker sole, and with the steel shank, which I'm very favor with the steel shank. I don't like the carbon shank because a lot of time carbon shank cracks.
Right.
The steel shank, it's very good, but in that study they did a double rocker with steel shank.
Yep.
And in my thinking, why would you use double rocker? Because if it's double rocker, we want the center of the shoe to collapse. But when you put the steel shank, it defeats the purpose.
Okay, I'm glad you asked. So I was part of that study. That was, and we had 40 subjects. And in our research, we had normal subjects because you can't have deformed feet. So we had normal subjects, and what our marker in the midfoot was the base of the 5th metatarsal. If you think of the midfoot on a normal foot, where can you measure pressure? Okay, so it was and we used actual sensors. So there was an insoles made for every pair of shoes that we've used in the study, and that was our marker. So and you know this, you know some of it and I'm real quick. I know we've got to go, but in the double rocker, okay, the base of the 5th compared to an unmodified shoe, everything was not. We didn't compare shoe to rocker sole to rocker sole. We compared the modified shoe to the unmodified shoe. Okay. In this one, the base of the 5th only decreased pressure by 4%. So that's significantly insignificant. I like saying that. In this one, we used a toe-only rocker sole. Okay.
Okay.
Here, the base of the 5th was loaded by 48%. So if you've got a rocker bottom foot, okay, that you need so basically, if you've got a rocker bottom foot and you don't need a rocker sole, just put them in a regular shoe. But if you've got a rocker bottom foot and you put them in this rocker rather than this one, you're going to increase pressure, according to our research, by 52%. Because here, when you're standing on this, all the pressure is here because you're taking pressure off here and here.
Yes.
So the shank is in there, but because there's not contact, it didn't decrease pressure a lot, but this one dramatically increases it.
Okay.
So that was the concept.
Yeah, but when the steel shank is in there, it's not the collapsing in the midfoot. It's going to be less.
Yeah, but it's still, the pressures were less. The pressures were less, and you could let it. But see, I don't want to let it sag too much. I don't want to go down to nothing here, and then have this collapse each time. Because if it's bouncing up and down too much, that could be trauma to start the Charcot over again.
Obviously, yes.
Good question. Thank you.
You're welcome. Thank you.
Hey, thanks, Alsa.
My pleasure. Thank you.
All right, we're going to grab. Donna wants to grab the mic. Definitely going to grab Donna. Bring her up.
Donna who?
Donna Robertson.
Donna Robertson. Oh, my goodness.
Hey, how are you guys? It's great to see you. This was awesome, Dennis. I'm so proud of you. We're so blessed to have you guys and the information you provided with us. It's phenomenal. I just wanted to make one point about a 4-foot lateral flare added to a double midfoot rocker to aid in continuous offloading of that midfoot.
Yep.
I have found that to be extremely beneficial. Dennis, you are the ultimate information giver on all of this. You're phenomenal. I tell you what, it was such a blessing to see you guys and to see Roger Mazzano. I tell you what, he still looks like a little kid. I could just tell you.
He is a little kid. He'll never grow up.
Awesome. But thank you, Dennis. This was exactly what we needed. And continue what you're doing. You're making a difference in people's lives every day. Richard, your magazine is so informative. I look so forward to every time I get a chance to read it. So thank you guys for what you're doing.
Thanks, Donna.
Thank you so much, Donna.
Thank you.
That's awesome. I mean, this is why we do what we do, Dennis. I mean, it's right there.
Yep.
Any other questions? Who else would love to come up to the stage?
And anybody that's got, if you don't want to ask a question, you guys are more than welcome to contact me, email me as well. So don't ever be hesitant on that.
Yep. Don't be shy. You know, Hillary, she is amazing. We did this great article of women in lower extremity medicine and featured back in the day. She is awesome.
Yep. Donna was, when she was sort of one of my students early on. I mean, when she got interested in pedorthics, but she's an athletic trainer, but then she also did reflexology. And then she'd do a Harris mat, with the athletes, and she could look at the Harris mat and tell them what muscles they had to strengthen by looking at the stupid Harris mat. I mean, I don't know where that came from, but she was unbelievable. I watched her do it.
Absolutely. You want to grab the mic, Hillary, and come up and say hello to us? Why not? Love to meet you. Aaron, obviously, you too. We know. Grab the mic. Come on up and say hi. Don't be shy. Awesome. This is what I love. This is the best part right here. Because we can't meet in person.
Hello there.
Hey guys, how are you?
Good. How are you?
Great, thanks. This class was awesome. Thank you so much. This was a great, full of information, which is really good. So Donna was one of my teachers and taught us so much. I feel like I'm like one of the young kids of pedorthics, but I've been in the footwear industry since I'm an athlete and a runner and kind of just wormholed into pedorthics. And now am working for a store in Sioux Falls, South Dakota. And we have a lab in the back and a guy that is incredibly talented and being part of doing all of our shoe modifications and stuff like that. So really talking about the rocker bottoms and stuff like that was super, super informative. So thank you so much. This was great.
Oh, awesome.
Thank you.
You're welcome. Absolutely.
I started, actually, I'm back in my hometown. I started in West Bend as a shoe repairman. That's where I came from. I didn't have the shoe sales background. I had shoe mods. So that's where I started 50 years. And I did a whole circle, and I'm back in my hometown now and doing the same thing. But the shoe mods, I'm not afraid to cut a shoe apart and put it back together. I can't draw a picture, but I can do things to shoes. But it's just Roger said it. The shoe mods are such an important part, and I'm hoping that the schools are doing a good job of teaching that, because you're not really caring for the patient properly, regardless of what problem you're treating. Unless you're working and thinking about the shoes.
You're 100% right. I think it is definitely a lost art. There's not a lot of people who can do it and do a good job at it and make it look good and make people want to be able to wear it. And I think if you're only putting an orthotic in the shoe, or you're only, doing one part of it, if you're not putting both puzzle pieces together, you're not really fulfilling your responsibility as a pedorthist and offering the best service there is.
Well, and I think your thing about it looking decent too. I mean, I've got people that come far and wide for elevations, but when I do an elevation, I cut the original outsole off. I match the EVA. I put them, and you got to remember, with a lot of our people, and I know this is I'm preaching the choir, but you have to remind yourself that for a lot of people, they can have diabetes, they can have a heart attack, they can have cancer, they have whatever. And they can wear the same clothes that you and I can wear, but when they have problems with their feet, it's such a burden and a consolation to have to wear special shoes. They don't want to wear special shoes, And so we need, when we modify that shoe, it's in their mind, it's ugly anyway. And if we make it uglier with the modification, they're never going to wear them. And then it's not doing anybody any good.
Yeah, this is just to show you guys, this is a little bit of, this is our guy, his little work area.
Okay, good.
With all his tools.
Awesome. It's much more organized than mine is.
Yeah.
Anything, but
we lost you.
He's super talented and does a lot of great stuff for us.
Awesome.
Yeah. So thank you guys so much. It was such a pleasure to be in the class.
All right, thanks for being here. Thanks for being here.
Hillary. I think. Let's see. Elsa wants to come back up. There we go. Oh, thanks, Leroy. Glad you were here, man. And Stu, I'm surprised you haven't requested the mic if you're still on. Hey, buddy.
Hey, Dennis, what's your input between lateral or medial flare versus lateral or medial stabilizer?
It depends on the I'm going to start with the flare if I can. And if the deformity is too great, I come up onto the shoe. Yeah. Right. I just had a guy. He's got a severe cavus foot. Somebody tried to do an ankle on him and totally screwed him up. And so he came to me for foot orthotics, and I said, "Well, I can do something with a foot orthotic, but I can't control your foot." And I explained to him. I said, "I'm going to build a buttress on the side of it." And, his eyes got real big. "What are you talking about?" And I said, "If you let me try this, I think it's going to make, you won't," because he kept falling off of the shoe, and a flare wouldn't be enough. I needed to come up the side of the shoe for him. The flare he would have came over the flare. I did it for him, and he walked around in here. He says, "I don't believe it." He says, "This is the first time in a couple of years I haven't walked out of my shoe. And I just got one." He's way up north in Michigan. He just sent me another shoe today because it works. So the flare wouldn't be enough. So we had to come up onto the shoe.
I have a patient with posterior tibia tendonitis, and he's he's almost navicular on the ground.
Right.
So I use the
stabilizer, medial
the stabilizer, and that helps a lot.
Oh yeah. Yep. Nope. It all depends on the severity of the problem.
Yep.
Okay, good.
Yep.
Thanks, Halsep.
Thank you.
Take care. That's awesome. Okay. I mean, we got 64, so a bunch of people still left in the room. If there's any other questions.
Hi, Stuart. I see you're here.
I know. He can't grab the mic because he says he dropped his phone in water, sitting in silicone packs drying out, so no mic.
What, were you fishing or something, or what were you doing? Maybe I don't want to know. Don't tell me. All right. Well, no, and again, for everybody, you have any toilet, that's what I was afraid of.
Only Stuart, although I've done the same. I really shouldn't speak on that.
No, so if anybody if anybody has any questions, you reach out to me. I'm always there for everybody, and I will respond if anybody asks me. Reaches out.
Yeah, absolutely. What an amazing event. So grateful to share the stage with you, Dennis. It's always an honor working together. PFA, top shelf. Just love the organization, love the people. Truly incredible team that we work with to bring this event. And to bring more events. We have the O&P workshop, the O&P Medicare and insurance billing workshop coming up in January with Matt Almeida and Althea. That's going to be Althea Powell. Is going to be another awesome event.
Sure.
Really just grateful everybody was here. Thanks, Irv. Really appreciate it. Things are getting easier and easier. This is where we're at for now. I'm with you, Dennis. I'm a hugger, as you know. I love seeing people in person. But if this is where we're at, this is what we're going to have to deal with. Really great. So good to see everybody. Good to see you. Glad everybody was here. I think we're going to say good night.
Everybody stay safe and well, and hopefully we see each other in person next year.
Absolutely.
All
right, buddy. Take care.
Take care, bye, everybody.
Well, so long. Take care, Roger. Take care, Steve. Karen, always great to.
Karen's here. Yep.
That's a good one. We should have did a little. We should have done a little.
Who's dropped the toilet? The phones in the toilets, right?
Chris Case, my man. Good to see you. Glad you were here, my friend.
All right. Take care, guys.
All right. Good night, guys.
Let's see you.
See you later.
If I can get out of here.
Yeah. Hit the lower left and the good on leave.
Gotcha.
Richard. Take care, Elizabeth. Have a good night, everybody.